Hello everyone, Gavin Greenfield here. We are going to discuss shock today. We recently spent some time in this space in Academy, so I thought I'd review it in the form of this video. For you non-STARS people out there, if you're wondering what STARS is or what STARS Academy is, there's a URL at the bottom left there that could bring you up to speed. Okay, what are some definitions of shock? Up to date has a definition that says life-threatening condition of circulatory failure causing inadequate oxygen delivery to meet cellular metabolic needs and oxygen consumption requirements, producing cellular and tissue hypoxia. They've got another definition that says a state of cellular and tissue hypoxia due to either reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of these processes. So I think it's important to understand what is meant by the term oxygenation. We use that term a lot. Oxygenation has two components. It's the hemoglobin saturation, commonly known as the SpO2, and it's how much of that gets delivered to the tissues. You could have all the sats you want, sats of 100%, but if you have no forward flow going to the tissues where it is required, you will have hypoxia at a tissue level. You will not have hypoxemia. I said the sats were 100%, but you will have hypoxia at a tissue level. And that's a part of the importance of understanding the definitions of hypoxemia and hypoxia. So potential consequences of shock, multi-organ failure and death. Now these definitions are great and they're accurate. And when we have time to think about them, yeah, they're useful. But in reality, the most of our patients, we relate shock to hypotension. Yes, we know from that definition on the prior slide that it's clear that patients with normal or even elevated blood pressure could be in shock. But again, most commonly, shock manifests with hypotension. So how can we approach a patient in shock? I just took the word shock and dropped the K, and we're going to have our four broad categories of shock. First, slack. This is the only one that I had to kind of fudge a bit, but slack refers to distributive shock, okay? The rest of them work really well: hypovolemic and hemorrhagic, obstructive, and cardiogenic. Those are our four broad categories of shock. Whenever you see a patient in shock, this was drilled into me when I was a resident and I floundered during a simulation. And I just didn't have this ingrained in my mind. And I think if I did at that time, I would have performed better on that simulation. But that was an opportunity for growth and improved my approach to shock, I think. So these are the four broad categories, and there's a mnemonic that can help you remember them. Let's go through each. So we're going to start with the S, which is slack, which is distributive shock. So what is this marked by? I'll give you a second to think about this. It's marked by peripheral vasodilation, right? We know that. The vasculature is slack, so to speak. Other names for this type of shock include vasodilatory shock and vasoplegic shock. What are some causes of distributive shock? Well, we know the most common one is septic shock. Right? Others, though, there are many others on this list, and they include things like neurogenic shock, so severe brain injury or spinal cord injury. Anaphylactic shock, most commonly seen with medications, insect stings, and foods. Endocrine shock includes things like Addisonian crisis and myxedema. Drug-induced shock, seen with agents like calcium channel blockers, beta blockers, opiates. And finally, toxin-induced shock. So we'll see that with things like snake and insect and spider bites. Also some infections that are associated with the toxic shock syndrome. Transfusion reactions and heavy metal poisoning are also less common causes of toxin-induced shock. So that's a list of causes for someone that we think is in distributive shock. And again, the most common one we'll encounter in our practice is septic shock. What's next? Hypovolemic. So what's this marked by? Reduced intravascular volume. Okay? Reduced intravascular volume. We can have hemorrhagic, or non-hemorrhagic hypovolemic shock. So hemorrhagic shock we commonly think of in the context of trauma, be that blunt or penetrating, but of course we can also see it in upper or lower GI bleeds, or ruptured AAA, postpartum hemorrhage, lots of things under hemorrhagic shock. Non-hemorrhagic shock would most commonly likely result from GI loss, diarrhea or vomiting, potentially just inadequate access to fluids. We can lose it through the skin though, through heat stroke and burns, renal losses, drug-induced or osmotic diuresis, salt wasting nephropathies, hypoaldosteronism, and third space losses like pancreatitis. Obstructive shock. What is obstructive shock marked by? Obstructive shock has an impact on the right ventricle. When I think of obstructive shock, I think of what's happening to the right ventricle. So it's a problem with either RV preload and or RV afterload. So let's talk about decreased RV preload. So preload definition is the stretch or length of the myocardial fibers at end diastole. And of course, the venous return to the right atrium and then the right ventricle is a major determinant of preload. So what are things that are going to decrease RV preload? It's things that tend to add pressure to the thorax, which then gets transmitted to that RV. So these are things like tension pneumothorax. Pericardial tamponade provides a significant amount of pressure to the right heart that prevents filling. Positive pressure ventilation can do this, right? Of course, when we're breathing now, we're under negative pressure ventilation. This creates negative pressure in the thorax on inspiration, which actually promotes venous return to the right side of the heart. But we change that physiology when we are pushing air in through a BVM device or a mechanical ventilator. Less common causes would be things like constrictive pericarditis and restrictive cardiomyopathy. We can also look at it from the point of RV afterload. So what are things that increase the afterload that the RV will see? It's going to be things like pulmonary embolus and pulmonary hypertension. Those things could result in obstructive shock as well. Okay, finally we have the C, and we have cardiogenic shock. This is going to be marked by, of course, decreased cardiac output. What are the three kind of categories that fit under cardiogenic shock? Give you a second to think on that. I recently took an adult learning on hour-and-a-half session through the University of Calgary, and if you want to retain things, you got to test yourself. It was very interesting, so I'm trying to incorporate that into my self-study. So that's what I'm doing now. I'm trying to get you guys to test yourself on what are the three categories of cardiogenic shock. But we'll move along, and so we can have pump failure. So if you have a big MI, or if you have heart failure that then have an exacerbation, a stunned myocardium following cardiac arrest, a tachycardia-induced cardiomyopathy, myocarditis, all these things can cause pump failure and result in decreased cardiac output. Arrhythmogenic, so atrial and ventricular, both brady and tachyarrhythmias can result in cardiogenic shock. And mechanical causes would most commonly involve valvular problems and most commonly severe insufficiency, but occasionally severe stenosis as well. And sometimes we can even see this acutely in the setting of an MI when we might see the rupture of a papillary muscle that will result in that acute valvular insufficiency. So those are the three categories under cardiogenic shock. So again, here's our mnemonic. We've got slack or distributive, and then we have hypovolemic hemorrhagic, obstructive, and cardiogenic. One thing that is not covered is this, when you look at some definitions, is inadequate oxygen utilization. So these would be things like carbon monoxide poisoning or cyanide poisoning, inheritable mitochondrial diseases. I don't personally think of these as shock. They certainly are by definition, but I categorize these things a little differently in my head and don't include them in the four broad categories. Okay, so you have this patient that's acutely in shock. It could be trauma, could be non-traumatic. There's a finite list of causes of shock that you can do something about right here and now. Okay, so let's go through this. They're all either hypovolemic or obstructive. So the first one, hemorrhage. What can we do about hemorrhage? We can stop the bleeding both local and systemic. How do we do that? Direct pressure, stapler, tourniquet, hemostatic dressing. Bind the pelvis, split long bone fractures and get them to a surgeon or an interventional radiologist. How do we stop the bleeding systemically? Well, in today's 2022, it tends to be things like TXA, but certainly also fixing any underlying coagulopathies. Tension pneumothorax. Well, what are you going to do about tension pneumothorax? You're going to decompress that tension pneumothorax, either with a needle or a finger thoracostomy and a chest tube, ultimately. Pericardial tamponade, you're going to evacuate that, either percutaneously or potentially with a thoracotomy. Positive pressure ventilation, you'd like to decrease your plateau pressure, improving compliance in that patient, doing things like sitting that patient up, removing any restrictive garments, removing seat belts. All these things can improve compliance in that patient and thus decrease the amount of positive pressure that exists within the thorax under the condition of positive pressure ventilation. Lower levels of PEEP, smaller volumes. All these things can potentially improve venous return to the right side of the heart. And for PE, how do we do that? We can lyse it, and we can get them to an interventional radiologist, on rare occasions also a surgeon. So when I see a patient in undifferentiated shock, I think of hypovolemic and obstructive first, and specifically under those two categories, I look at these. And the reason I do that is because these are more fixable acutely than cardiogenic shock is, for example. Now, it's not universally true. If somebody's in a tachyarrhythmia, that's pretty fixable, usually with electricity if they're that unstable. But an LV pump failure is not acutely, fixable, at least to the same degree as things are on this list. Distributive shock, again, not acutely fixable. If we use septic shock as an example, yes, we're going to treat the infection with source control and antibiotics and treat the hypotension with vasopressors. But again, not as potentially a rapid fix as what we have on our list here. So I think a good understanding of the four broad categories of shock: distributive, hypovolemic, obstructive, cardiogenic, and then the big five within that, which are only under hypovolemic and obstructive, to turn your attention toward those ones first. Make sure you don't have a situation on this slide that exists, and if you do, fix it. I think having that, especially in trauma, but even in undifferentiated non-traumatic causes of shock, I think that that's helpful. So the take-home message: 4 categories of shock. Distributive, we use S as slack as the parallel for that. Hypovolemic, obstructive, and cardiogenic. Remember the big 5. And for you non-STARS folks out there, this is where you can find the CCMCP on shock. I think this actually needs a little bit of work. We don't have an obstructive shock CCMCP. But as we all know, this is a resource that is in constant evolution, and we'll get there. So thanks very much, everybody. And with that, I will sign off. Go Flames.